Good afternoon and welcome to today's webinar, Key Public Health Initiatives, A Year in Review, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Chong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. Please feel free to submit questions at any time by using the Q&A tab on the right-hand side of your screen. We strongly encourage attendee participation in our webinars and would love to hear some of your thoughts and questions. So all you need to do to submit a question is click on the Q&A tab, select all panelists from the Ask drop-down menu, and submit your question. If you do not see the Q&A tab available, click on the button with the three dots highlighted in the picture. Your moderator for today's webinar is Kathy Hoke. Kathy is the Director of the Network's Eastern Region Office, the Director of the Legal Resource Center for Public Health Policy, and a law professor at the University of Maryland. Kathy provides legal technical assistance and works with state and local health officials and legislators on developing and implementing tobacco control, obesity prevention, and injury prevention policy. Kathy will be leading us through the rest of today's webinar. So Kathy, over to you.
Thank you, Charles, and thank you everyone for joining us this afternoon. Or for some of you this morning. I have the distinct pleasure of introducing four folks who I laugh when I look at their short bios that were prepared for this because I know them way better than this. But I dare not tell you their secrets, so I will just stick to some biographical information about them. This is the staff of the Eastern Region for the Network for Public Health Law, situated at the University of Maryland Carey School of Law in Baltimore. So first up, you're going to hear from Melissa Sager. Melissa is a senior staff attorney with the Network's Eastern Region. She is also a senior staff attorney for the Legal Resource Center for Public Health Policy. In both of these roles, she provides legal technical assistance to state and local legislators, health officials, NGOs, and community coalitions working to improve public health through law and policy change. Melissa has a broad scope of practice, and one of her issues is scope of practice. So Melissa has done a lot of work in the area of the scope of practice for various health professionals, including nurse practitioners, dental therapists, and pharmacists. She also has worked a lot on issues associated with opioid issues here in Maryland and is the Government Affairs Director for the Center for Problem Gambling, which is situated here at the University of Maryland School of Medicine. So we'll first hear from Melissa. Then we'll hear from Brooke Torton. Brooke is the Deputy Director of the Legal Resource Center for Public Health Policy. In her position, Brooke does basically everything. I would call her the queen of tobacco here. So she develops toolkits, policy papers, drafts legislation, does a ridiculous amount of in-person training and meetings with community coalitions throughout Maryland on tobacco control and prevention. She is all things Juul. And by that I mean J-U-U-L, which she's going to talk with you about a bit, and is leading our efforts in support of the Tobacco 21 legislation that will be introduced here in Maryland. Both Melissa and Brooke are former students of mine through the Public Health Law Clinic that I direct here at the law school. Next up will be Carrie Lowry. Carrie is the Deputy Director and the Director of Research and Grants here at the University of at the Network's Eastern Region. Carrie has 20+ years of experience in health law and policy research. Hence, she was never my student, but she has conducted significant work in primary and secondary legal and legislative analysis, empirical legal and legislative research. She has her MPH and uses it effectively here, explaining to us lawyer dullards what p-values and confidence intervals and all that stuff really means. Carrie's areas of focus have included youth sports injury, more broadly traumatic brain injury regardless of the cause, cancer prevention and the role of law, health disparities, and legal and ethical implications of emerging technologies. Carrie also is one of our lead speakers on understanding the difference between permissible advocacy and impermissible lobbying for public health officials. So if anyone's interested in information on that, please reach out to us. Carrie has really developed an expertise in that area. Carrie is also developing an expertise, has a baseline expertise, and is further honing in on the expertise in data and privacy issues. And so again, I encourage anyone to reach out on those issues, particularly those from the Eastern region. And then we will wind things up with Matt Swinburne. Matt is the Associate Director for the Network's Eastern region. He is also a former student of mine. Matt provides legal TA as well to the same groups that we all provide legal TA to. Matt has become our go-to person on medical cannabis, and marrying his two loves, because his second favorite area is food insecurity and food safety, and so Matt's doing a significant amount of work now on cannabis edibles. So I thought it was cool the way he was able to join up his two favorites. Matt also does a significant amount of work in telehealth, health equity, environmental health. He has done some really good work on broadband access as a public health issue. And so for those of you who might be particularly in rural communities struggling with some of those issues, please do reach out to Matt. He would, I know, love to talk with you further about that. So on that note, I'm going to turn things over to Melissa to get us started.
Thanks, Kathy. So I'm going to start things off with scope of practice, and my presentation is a bit broad because I'm going to touch on a few provider statuses. My colleagues, I know, are getting a little bit deeper into their topics, but I kept this broad to touch on a few professions and then hopefully solicit questions. I'm happy to chat about any of the professions. I know the announcement talked about nurse practitioners, physician assistants, community health workers, and peer support specialists, all professions that I have looked into, but I narrowed it down to 3 in this webinar. Happy to chat about any of them. So first, what is scope of practice? So scope of practice is generated through state law, often called a Practice Act. It's narrowed down farther in regulation, and then through licensing bodies like the medical boards, pharmacy boards, dental boards, and they're really getting down into the details about the rules of what a medical professional can do in their practice. So what care can they provide, what are their limitations, when and where they can do that, what information they need to provide, who they need to check in with and report to, all of those type of things. Again, starts very broad at the state level through state statute, is narrowed down through regulation and licensing bodies. The provisions are often tied to education, training, and experience. They're referenced, if you have this type of education and training, you're permitted to do these type of activities. They were originally designed to protect the public, public safety, to make sure certain medical professionals aren't going into something that they're not trained to provide, providing services they're not trained to. I just noted here at the bottom that both physicians and non-physicians, so we're talking about these other providers, have a financial interest in scope of practice laws because they impact really all of the practice, what they're allowed to do, the limitations of those practices, how far out into the community they can go, who they can see, that type of thing. And it's important to keep that in mind as you go through looking at these policies, who's weighing in on them and what the motivations of those are. Common restrictions placed on providers, supervision requirements, so a nurse practitioner requiring supervision under law from a physician. Another type of supervision requirement is a collaborative practice agreement that requires, I'll use a nurse practitioner example again, a nurse practitioner to contract with a physician who then they're checking in with on a semi-regular basis, or that physician can be in person or not. It depends on the state law. I could talk about collaborative practice agreements for a very long time, but I'm happy to provide more information. Prescribing limits, what a provider is allowed to prescribe, sometimes nothing, like a dental hygienist, or sometimes it's limited. So in states we see that nurse practitioners are not allowed to prescribe opioids. Location restrictions, so sometimes these mid-level providers are able to provide services out in rural communities, and that's it. So the law says that we need you in these rural communities where we don't have folks, but you're not allowed to provide that service in other areas. Hospital and admitting privileges, so sometimes nurse practitioners are prohibited from providing care without supervision in a hospital. So anytime they would like to provide care within a hospital setting, they require supervision from a physician. We see that with nurse midwives as well. And referral requirements, so requiring a person see a primary care provider before accessing certain services from mid-level providers. All of these limit when and where a provider is able to provide care. The public health implications, and I won't read all of this to you, but 20% of Americans have a difficult time accessing care that they need, and whether that be location reasons, it's too far away, or cost restrictions, the current system is not reaching 20% of Americans that need care. And it's something that we need to address, and I'll go over how the scope of practice expansions may be able to touch on that. So allowing providers to practice to the full extent of their education and training can increase access and decrease costs. So we're talking about medical professionals who are trained to provide services, being able to reach communities with those services. And when we allow people to go out into the community, they practice in unique settings, provide care at a lower cost, it's easier to access, and I'll go through those in the professions that I cover here. So first, pharmacists. This is something that we've seen in a lot of states, expanding a pharmacist's ability to provide additional care. So not limiting a pharmacist to just prescribing medication, but allowing them to do medication therapy and disease management. So pharmacists are trained in school and through their work training to provide this type of care. They're educated to do so. They know the information. They know the patients. They have access to even more information than physicians sometimes through PDMPs. And they're able to do these things. And what we see is some states allow pharmacists to do that. They are able to provide flu shots, injections, and then more recently we've seen pharmacists with the ability to prescribe medications. So naloxone here in Maryland in 2017, it passed that pharmacists can prescribe birth control, and we've seen that in a few other states. And this year they'll be considering legislation on tobacco cessation medications. And so allowing pharmacists to do this provides a location with oftentimes right in the community, open oftentimes 24/7, where people can access this regular care where otherwise they're not. So not stepping on the toes of a doctor, but having those resources available for people who otherwise wouldn't access them. And then ensuring within these scope of practice laws that pharmacists are referring patients out. So when they're touching on a patient that otherwise wouldn't have received care, they're also saying there are other resources that you can access. You should see your primary care doctor about these issues and things like that. The next profession I have here are dental hygienists and dental therapists. This is a little unique. States have taken a few approaches. It's very similar to pharmacists getting people out into the community to practice. The dental hygienists are able to clean teeth for those in rural areas, in long-term care settings and schools. So populations that otherwise wouldn't receive this care are able to be assisted by dental hygienists and dental therapists. They have expanded scope for dental hygienists in areas that they can practice. They've removed supervision requirements in certain settings so that a dentist does not have to be right there. And again, they're doing these limited scope of services like teeth cleaning. We've seen others and evaluations, and again, they're referring back out to a dentist. So people who wouldn't have received care are getting referred out when it's necessary. And then we've seen states create the profession of dental therapist. So rather than expand the scope of a dental hygienist, they've created a new position of a dental therapist that's allowed to do an expanded scope of work with things like teeth cleaning, which overlap with hygienists, but also x-rays, fillings, crown replacements, things that are very routine and don't necessarily require oversight of a dentist right then and there. And lastly, I have nurse practitioners. I think this is a profession that many people are familiar with. It's one of the ones that have made very far advancements in this area. Lots of folks, myself included, have a nurse practitioner as a primary care provider. But we still see states putting limitations on nurse practitioners, like prescribing authority, not allowing certain prescriptions to be prescribed by a nurse practitioner, or requiring or not allowing a nurse practitioner to be a primary care provider under state law. And that limits access for folks. If a nurse practitioner is in your area but they're not considered a primary care provider, maybe you can't get the pre-authorization you need for certain services in a specialty area. So all of these restrictions really place a burden on the system because these professionals are trained to provide this care. Research shows that this care is safe. Patients enjoy working with, maybe they enjoy seeing a dental hygienist rather than a dentist. They feel more comfortable, or a nurse practitioner has been trained differently to engage with patients, and they'd rather work with a nurse practitioner. But these restrictions limit that ability and limit choice and access. I put this diagram in here. This is from the scopeofpracticepolicy.org, and it's run by ASTO and the CDC. Don't quote me on that. But this website is a fantastic resource for scope of practice laws, and they update it fairly frequently, and they have 3 professions on there. This is the nurse practitioners state, but it gives a great visual of what the limitations really are in those states. And if you get onto the website, you can click on those states for a bit more information, but I wanted to make sure you had that. I have this other consideration slide. I touched on it 2 slides ago, but outside of public health, we've seen arguments come in or just describing how this benefits beyond health. So when you allow medical providers to practice to the full extent of their education and training, you're increasing business opportunities. You're increasing the number of providers in your area. People often, we've seen studies show that people come to certain areas who have expanded scope. So a nurse practitioner who's graduated is more likely to go to a state that has full practice authority, where maybe they can practice independently, as opposed to a state that doesn't. It increases patient choice. Again, I touched on that. You know, if you feel more comfortable with your nurse practitioner and you want your nurse practitioner to be your primary care provider, it should be an option to you if they're trained to provide safe care for you. And then continuity of care. I put this in here really for all the medical providers, but pharmacists is what triggered this for me, and just having, allowing a pharmacist to do medication management, for instance. Again, they have access to a database that shows every prescription that you're taking and have taken in the past, whereas maybe your primary care provider doesn't have what your physical therapist has recommended, or a knee specialist. They don't know that you're necessarily taking these certain medications, and a pharmacist can look at that. And so just to conclude, scope of practice policies need to be evidence-based. Professions can demonstrate what they're able to provide to patients safely and effectively, and when they do that, that's what policy should be based off of. Professions can and will overlap in scope of practice, and we see that come up if you know, a nurse practitioner is allowed to do this. It does not take away from what a doctor is allowed to do, or the work that a doctor is doing. And so we will see overlap, like we saw with the dental therapist. A dental therapist overlaps with a dental hygienist oftentimes, and that's okay. Patient safety and wellness should always be the primary factor. There's a lot of information out there as far as what other countries have done with scope of practice, and we've seen lots of states move toward this, and we're keeping an eye out to see the impact on health. And then reimbursement, the last point, reimbursement policies, insurance policies, organizational policies, and educational opportunities all still limit this. So if you have a pharmacist able to prescribe birth control, but they can't obtain any reimbursement for that service, it's very difficult for them to be able to do it. So expanding the scope there doesn't necessarily increase access if then they're cut off and not able to provide the service. So it's this full circle approach where you have to keep in mind these other limitations on the services. So that's what I have for scope of practice. I know it was very broad. We have a lot of information on what states are doing, what they have been doing, and what they're moving towards. And if you have any specific questions about any of the other professions, any of the specifics on what I've covered here, I'm happy to chat about it more. Just reach out to me, phone or email. And that's all I have.
Awesome. Thank you, Melissa, very much.
Thank you.
So, folks, start writing those questions in the Q&A, and I'm going to turn things over to Brooke. Can't hear you, Brooke, so if you're talking, unmute yourself. Brooke? I can't hear you. Are you unmuted in both places?
I thought, Kathy, I didn't.
Right, here I am. Sorry about that. All right, thank you so much. All right. All right, so let's get started. So today I will be talking a little bit about the deeming rule, but more specifically vaping and juuling and what's happening at the FDA at the federal level here. So let's go all the way back to, not Melissa's presentation, but to 2009. And just to really briefly give a little bit of a refresher here, the Tobacco Control Act in 2009, this is the first time that the FDA was given authority over tobacco products. And it required that they adopt certain requirements for all tobacco products under its authority. So like I said, prior to that time, they could not actually do so. They previously tried to, and the court said, no, you are not allowed to do that. You can do it, but not in the way that you were this time. So finally, they did do this in 2009. And so this authority at that time, it only extended to cigarette tobacco, and roll your own tobacco and smokeless. This did not apply to electronic nicotine delivery systems. And that's really because although they had seen them, they had entered the market at that point, it was very minimal. These were not products that had drawn the attention really of anyone, and they were not seen like they are today. They were not being used like that then. But importantly, the Tobacco Control Act in 2009, it gave the FDA the authority to issue future regulations deeming other products subject to the Act. So they recognized that there would be enhancements, there would be developments in technology that would make it such that there were products that weren't covered, but that they may want to cover at some future date. And so that is where we move forward a little bit, and we get to about 8 or 9 years later, we have the deeming rule. And the deeming rule became effective August 8, 2016. So this is what provided the FDA with the authority to regulate new products. So really for our purposes, we're talking about electronic cigarettes being regulated, but cigars were also regulated at that time as well. Okay. And there are some other products in here too, like pipe tobacco, hookah, shisha, but like I said, we're really focused on electronic nicotine delivery systems here today. All right, so the deeming rule, it did many things, and I've kind of classified these into manufacturer requirements as well as retailer requirements. So as far as the manufacturer, at this time, what the deeming rule said was that manufacturers were going to have to do all of these things. So report product and ingredient listings, register with the FDA, report harmful and potentially harmful ingredients, having health warnings on product packages and ads, not making these reduced risk claims without scientific data and FDA approval. That is of particular importance because we would hear quite a bit that, electronic nicotine delivery systems, that these can help folks quit. And whether or not that may or may not be true, there certainly wasn't enough evidence to support that conclusion at the time that these statements were being made. And the jury is still really out on that one to a great extent. Then not using descriptors like light, low, and mild, because obviously that communicates that there's a minimal or a reduced risk. No false or misleading claims in labels or ads. That's a little bit of a broader requirement there. And then paying user fees, and that's something that we've already seen with the traditional tobacco products. So being subject to pre-market review, this is of importance, particular importance really to our discussion, and that is because essentially what these manufacturers were going to be required to do pursuant to this rule was submit these applications. They were to submit these applications if their product was not commercially marketed by February 15th, 2007 in the United States. And of course, at that time, none of these products were commercially marketed by that date. So in turn, what that would do is that would require every single manufacturer of an electronic nicotine delivery system to submit an application for pre-market review. And so that was a requirement, and I'm going to talk a little bit about that, how that changed and how that altered over time. And then we have the retailer requirements. So they established the minimum age of 18 for folks who wish to purchase these products. Before this, there was no minimum age to purchase electronic nicotine delivery systems. And then we have the ID check. So retailers are required to check folks who appear under the age of 27 and request identification. These products would not be permitted in vending machines. And also there's no distribution of free samples. And so that's already something that we've seen with traditional tobacco products. All right, so let's talk a little bit about what are these electronic cigarettes. So many of you have probably seen them and know a little bit about these. But these are these battery-operated products that typically heat nicotine, flavor, and other chemicals into an aerosol that the user inhales. And this can really include quite a variety of devices that look very different from one another. You have electronic cigarettes, e-hookahs, e-cigars, vape pens, these advanced refillable personal vaporizers, and electronic pipes. And you've probably seen people, walking down the street with all of these devices at some point in time. And the vapor is inhaled, like I said, and we're seeing that inhaling is referred to as vaping, or most importantly, juuling. Now juul is an actual product, which I'll talk about in just a second, but it has actually become a verb. So it doesn't mean you have to just be using the juul device, that product, but you can be using a product that is like a juul. It might be another brand name, but someone might still say, yes, that is juuling, just because they're using the similar device. So is juul an electronic cigarette? Yes, it is a very specific type of electronic cigarette. Juul, it resembles a USB, which makes it particularly difficult for parents and for teachers to detect when a minor, a child, is using these products. If you hold them up next to one another, you can hardly tell the difference. I even have trouble, and this is what I do for a living. It can be very difficult. So the liquids in these juul pods, they have these nicotine salts, and so they're absorbed into the body really quickly. It's almost at the same rate as a combustible cigarette. So the vapor is inhaled more smoothly than combustible cigarettes. It goes down a little easier, and so that makes it more attractive, more appealing to younger folks. And really, most notably, juul has more than twice the amount of nicotine as many other brands of e-cigarettes, which of course is of great concern for our youth, because this is going to accelerate the rate at which they would become addicted. It's of great concern. I also want to say the reason we talk about juul is because juul has 72% of the market share for these types of products. And so that's really why it has become a verb to some extent. There are other companies as well, but juul is of particular interest for a couple of reasons, and the FDA has actually taken a unique or particular interest with juul products as well. All right. And so just some statistics. I'm going to talk about this a little in just a minute, but high school student e-cigarette use has increased between 2017 and 2018 by 78% among high schoolers. Now, middle schoolers, another huge rate increase, a 48% increase among middle school students. And so presently, there are more than 3.6 million middle and high school students that have been considered past 30-day e-cigarette users. We say current users, and that means past 30-day. That represents a 1.5 million student or minor increase since 2017. So obviously this is of great concern and this has caught the eye and the attention of the FDA most recently. And I'm going to talk a little bit more about some announcements that have been made and what the FDA is looking to do. So before we get to that, to present day, I'm going to take you back, not as far as to 2009, but to 2017, July of last year. And so on July 28th, 2017, the FDA, the Commissioner, Scott Gottlieb, he announced a plan to develop regulations lowering the nicotine levels in cigarettes, and this was to potentially non-addictive levels. And the idea was that if we can reduce the addictiveness of these of cigarettes, of tobacco products, users might be more likely to quit, and then youth, of course, would be less likely to ever begin smoking. And so this was a new idea that they were taking comments for, and they wanted to conduct some research studies before they really put a regulatory scheme into place. But because this was a new way of looking at tobacco products, the Commissioner announced that the deeming rule, some of those key portions as it relates to electronic cigarettes and cigars, they were going to be placed on hold for several years. Now remember, I mentioned a little bit about the pre-market review applications. When the rule was announced, even before this announcement here, when the rule was announced back in May of 2016, then became effective in August of 2016, the guidelines were that, you know, you are not going to have to comply with this immediately. You are going to have a grace period until 2021 or 2022, depending on the type of application submitted. We're not going to make you remove your products from the market as long as you've got something pending with us, a pre-market application. By that time, you're fine. What this announcement did a year later, July 2017, was it said, you know, you are not going to have to potentially even worry about this then. We're going to place this on hold for even a little longer, potentially. All right, so then fast forwarding to just a few months ago in September of 2018, essentially the FDA, they announced a series of critical and historic enforcement actions related to the sale and the marketing of electronic cigarettes to children. And that's because they started seeing data like what I referenced a little earlier with these huge increases in youth use. So they sent out, over the summer, before this particular September 2018 announcement was made, they sent out 1,300 warning letters, civil money penalties they issued, they had no tobacco sale orders. And so the agency, they also sent letters to Juul and some of the other companies requiring that they submit these documents to help give the FDA an understanding of what could potentially be the reason for these high rates of youth use. What's the appeal here? And I also just want to mention that the majority of those violations, so those civil money penalties and warning letters, the majority of those came from these 5 big companies. It's Vuse, Blue, Juul, Market 10XL, and Logic. And so those companies actually represent 97% of the U.S. market share for electronic cigarettes. So the majority of these violations are coming from the majority of the market shares. All right. So the FDA, they also requested that manufacturers take these voluntary steps to help curb youth appeal. And it says voluntary, but what the Commissioner said was, if this is not appropriately addressed, we will consider revisiting our current policy, which allows these products to remain on the market. Specifically, Scott Gottlieb says, let me be clear, everything is on the table. This includes the resources of our civil and criminal enforcement tools. So this was really a really important statement. It's a really important remark. The manufacturers this time, they realized we are, not flying under the radar, and we need to somewhat cooperate with the FDA at this point, provide information, and be part of this conversation. So fast forwarding just a month after that, in October of 2018, again, we're seeing another press release, another statement from Scott Gottlieb. The FDA sent letters to 21 electronic cigarette companies. They were looking for information about whether more than 40 products, including some flavored e-cigarettes, were being illegally marketed and outside of the agency's current compliance policy. And so he also mentions that flavors are the principal drivers, that's the phrase that was used, of youth appeal. And so there's a particular interest in studying the way that these are working with youth use. Are they using them? And there's just particular interest in learning more about that at this point. He also announced there was a meeting with some of the bigger electronic cigarette companies, and it was interesting. What he said was there were some statements that they all agreed about. The group that he met with, and they're listed here on this slide, they acknowledge the health concerns that have to do with youth use, and they understand that preventing youth use would be a priority. They also did acknowledge the role that flavors play. And some of the companies also referenced increasing the age of access to 21 as a way of curbing youth appeal. All right, now moving forward to 2018, the CDC released some of those figures that I just referenced. Again, that was that 3.6 million high school and middle school students were current day users. There was that 78% increase in high school student use from 17 to 18, and that 48% increase. Youth who were using were also using more frequently. That was on the rise. And of course, there was a study, a mention about significant increase in flavored e-cigarette use as well. So at this time, what Scott Gottlieb says is we're going to revisit the compliance policy on several different issues here. So one, revisiting the compliance policy as it relates to all flavored ends products that are not sold in age-restricted locations. So that might potentially place a limit on online sales as well. And then he talked a little bit about revisiting the compliance policy on flavored cigars, banning menthol and combustible tobacco products, and removal of products marketed toward children. And so I do encourage everyone to take a look at this statement. It is very specific about what the FDA is intending and where it may go. So just a quick word on this. There have been some lawsuits also initiated. These have mostly been against Juul. We see Pax Labs, I believe, owned Juul at one point, and so sometimes the lawsuits filed against one or both here. And so what we see is these different claims being made, mostly related to labeling and false advertising. They might deal with packaging, the kinds of chemicals included here, and just the fact that these pods are containing a great deal of nicotine content. This is something that people are concerned about in these lawsuits as well. And of course, we see a problem with the marketing practices. We see very young people here being marketed. I don't believe Juul is using these hashtags on social media like this anymore, but of course, this is a grave concern. None of these lawsuits have been decided yet. They are taking place. They are in the trial court level and federal court now. All right. Well, thank you so much. I will now turn this over to Carrie.
Thank you, Brooke. I hope everybody can hear me okay. So it's totally switching directions here. I'm going to share with you some research that I've been working on for the past several years with a focus on what I've been really concentrating over the last year or 2 years, which is return to play laws in the states, but also returning to school after mild traumatic brain injury or concussion. So just a roadmap of what I'm going to try to cover. First, I'm going to review for you state return to play laws and the associated return to learn provisions, which states have them, and then also what we learned from people who were implementing both of these types of provisions in the states based on a convening that we did and some interviews that I did by phone. And then I'm going to talk about one of the main lessons learned from one of our most recent projects, which was which federal laws really pertain to students who are returning to school after TBI. Okay, so first of all, establishing that youth sports-related injury really is a public health problem, and why. The impact of on child and adolescent health is huge, and it's actually worldwide. In this country alone, there are almost 8 million high school athletes, and that's probably a gross underestimate. And there are about 35 million kids that play organized sports each year in this country. Again, another underestimate. It doesn't include kids who are under the age of 6, for example. I know that my kids both started playing soccer at age 3, and I put soccer in quotes. If you could see me, I'm doing air quotes. So there are really many, many more kids who are impacted by the potential for sports-related injury. And then specifically related to TBI, for young people aged 15 to 24, sports are actually the second leading cause of traumatic brain injury, second only to motor vehicle crashes. And there is an argument that the evolving culture of youth sports in this country is perhaps contributing to the public health burden, things like specialization in sports at younger and younger ages, resulting in overuse injuries, pressure, and even impacts on mental health. Okay, so here is some research that I did in 2011 and updated through 2014, showing when states passed these return-to-play laws, first when they were enacted, and how many states had the laws as of the year indicated. So you can see before 2009, Texas was the only state that really had a law that addressed concussion in some way and knowledge of concussion and the risks of returning to activity too soon before a concussion is healed. And then as of 2014, every state and the District of Columbia had such a law. Mississippi was the last state to pass such a law in 2014. So these laws all share pretty much three common provisions, and these are all really based on the Washington state law, which is one of the laws that was passed in 2009. The big three are education for student athletes and their parents, sometimes with a signed information form and sometimes not, immediate removal of a concussed athlete from play, and then some kind of return to play restriction with a medical evaluation. So the states all really vary in terms of who can make that kind of return to play determination, what kind of medical provider is qualified. These big three, as I've called them here, potentially may leave out some important factors that other states have added, such as mandatory training for coaches and for officials, baseline testing, so you have some idea of cognitive functioning of an athlete before and after injury so that you can more accurately assess whether the student's getting better. Also, requirements for medical personnel on the playing field. Vermont was the one state that had such a law, and I believe Iowa this year added a permissive or encouraging provision to have medical personnel on the playing field when at all possible. Some states have actually tried to incorporate primary prevention or preventing concussions from happening in the first place. One of the criticisms of these laws early on was that they were really aimed at secondary prevention and, kind of mitigating the effects of concussions that have already happened as opposed to preventing them in the first place. So some states are doing things like limiting minutes of full contact practices and scrimmages. There's some interesting pushback from state organizations like high school athletic associations on that point that's valid, I think, that perhaps the state legislature, because they can't change laws quite as quickly as an athletic association can change their regulations, perhaps isn't the right place for that kind of regulation, but it's an interesting conversation that I'm happy to have with any of you who would like to contact me and talk about it. Also training for school nurses and educators, which leads to this, it's called return to learn, which is kind of a neat phrase because it rhymes, but most of the experts in the field prefer the term return to school because return to learn leaves out the all of the issues related to returning to the building and the environment itself with crowded hallways and fluorescent lighting and all of that, in addition to the cognitive aspects. Okay, so before we talk about lessons that we've learned from implementing these return-to-play laws, I have to show you these pictures, mainly because every time I talk about concussion, I share them because I paid for the rights to them. So this is a football field in Barrow, Alaska, and that is a polar bear that you see there. And this is that same football field from a helicopter. And so that you can see what kind of community we're talking about here. This is a very rural whaling town in northern Alaska where there's just not a lot of access to medical providers. And this is actually directly related to something that Melissa talked about with scope of practice and allowing providers to practice to the full extent of their training. So this is what Alaska's law said when it was originally passed in 2011. I'm only going to read the part in red, but basically this says that if a student's been removed from participation, they can't return until they've been evaluated by a qualified person who has received training and is currently certified as verified in writing or electronically by the qualified person in the evaluation and management of concussions. Now, at this point, usually I poll the audience, how many providers who are in the audience would feel comfortable and qualified, especially in 2011, when this was all still relatively new, making that kind of a determination if the law said that you had to be qualified and certified. So the interesting thing to note is when we talked to people in Alaska, there actually is no process, or there wasn't at the time, any process for certification in the evaluation and management of concussion. So as you might imagine, this had a chilling effect on providers who were willing to make return-to-play decisions. And in a community like this, that is very problematic. So in 2012, after the law had been in effect for less than a year, the legislature actually changed the wording of the law to read this, like this. So they added athletic trainers who were providers who were qualified to make a return-to-play decision, expanding access to athletes for these kinds of evaluations. And they removed that current certification requirement in order to kind of alleviate that issue that they were having where providers were not willing to make the return-to-play decision. Okay, so other kinds of changes that we have seen since original enactment. As of June 30th, 2017, 35 states had made substantive changes to their laws. And I say substantive because, some states recodified or made other kinds of changes that weren't substantive to the requirements of the law. Most amendments could be categorized into three types. They either expanded coverage, they added primary and other kinds of secondary prevention measures, or they tightened requirements or clarified provisions. And interesting to note, too, and in the interest of time, I'm not going to tell you all of the changes that have happened in the last couple of years, but suffice it to say that a few states added training for coaches in 2018. In 2017, like Arkansas, for example, established penalties for coaches who don't meet training requirements, which is interesting. We very rarely see enforcement kinds of provisions in these laws. Like Montana expanded coverage to private schools, and also, interestingly, Nevada and Texas, two states that have rural areas and have an interest in expanding the access to providers for these kids, actually added advanced practice nurses and chiropractors, respectively, to the list of providers that can make return-to-play decisions. So as of September of this year, 6 states had also added return-to-learn provisions to their original return-to-play laws. And I do not know what happened to this slide, Charles, but that looks weird. Anyway, there are 12 states that have added some sort of return-to-learn provision to their return-to-play laws. They are Hawaii, Idaho, Illinois, Iowa, Maine, Maryland, Massachusetts, Nebraska, New York, Oklahoma, Vermont, and Virginia. The laws vary significantly in scope, in the specificity of their requirements, and in the, how they delegate responsibility. So, for example, both Virginia and Massachusetts require school accommodations, quote, as deemed appropriate by the injured student's healthcare provider. This is problematic to many experts in this field because they deem this to be a poor standard given the vast variability in concussion knowledge among primary care providers. Another example is Nebraska's law says only that a return-to-learn protocol has to, quote, recognize the potential need for accommodations and monitoring by school staff, but it doesn't provide any details about how this should actually happen. So here's an example of Iowa's new statute that became effective this year. It states that a concussion can impair not only the physical abilities of a student athlete, but can also affect how a student athlete thinks, acts, feels, and learns. A student athlete who has sustained a concussion may need informal or formal adjustments, accommodations, and modifications of curriculum. This is a positive step in the right direction because it shows that legislators are starting to notice that that MTBI is not just a physical issue, but can also really impact a student's learning. So over the last couple of years, we had a project with the Center for Disease Control and Prevention Injury Center, and we were able to talk to implementers of return to learn policies, and we held a convening of stakeholders at the University of Maryland Law School in 2006, and we spoke to several key informants. And here's what we learned. We learned from them that policies that focus on athletics, like these return to play laws, in which are embedded these return to learn provisions that we just talked about, do not cover all students who experience a TBI and return to school. So we learned that there are students who get a concussion either because they're involved in a minor car crash or they were in a bike accident over the weekend, or were riding a horse, or even got shoved into a locker and hit their head, as one of my friend's kids did. And so these policies aren't really designed to set up a protocol because they're not involved in the return to play protocol for students who don't sustain their TBI during school sports. So these policies often do not prioritize return to school over return to play for athletes even that are recovering from TBI, and the interplay between this return to play legislation that includes the return to school provision and the services under existing federal laws, so we'll talk about these briefly, is really not clearly understood by schools or by parents, by educators. And so that was an area that was really identified as needing clarification. Finally, state return to play laws that contain these provisions can be an important tool, but they can also contribute to this conflation issue of return to school with athletics, leaving out the kids who sustained their concussion through other modalities. So some of the other work that we did was really to clarify for schools and others how these federal laws that are designed for students with disabilities actually may pertain to students with mild TBI, and to explain to them when they may pertain and when they may not. So Section 504 of the Rehabilitation Act is the first one that's really usually invoked when talking about kids returning to school with concussion. Section 504 is a civil rights law that's designed to protect students with disabilities from discrimination. It requires schools to provide what's called a FAPE, or a free and appropriate public education, to kids who have physical or mental impairments that substantially limit one or more life activities, and that is the language in the law that triggers the requirements. So schools have to provide students with disabilities an appropriate educational service in order to meet their needs to the same extent that the needs of students without disabilities are met. This law may, and I say may, apply to students with concussion or mild traumatic brain injury where their recovery is prolonged, and this is often seen as a case-by-case determination. At the elementary and secondary school level, the law requires an individual evaluation to occur that will determine whether a student is qualified for a 504 plan. A medical diagnosis is not an automatic qualifier, and this is frustrating for a lot of parents, but the evaluation has to determine that the impairment that the kid has actually substantially limits their ability to learn. And a temporary impairment does not constitute a disability under 504 unless its severity results in a substantial limitation of a major life activity. So you can see how this would have a chilling effect on being able to apply this to students with concussion, because often they resolve within 3 to 4 weeks. So again, what is a substantial limitation? There were amendments in 2008 and ADA regulations in 2016 that clarified that this major life activity can include things like returning to school because of the impacts on learning, thinking, concentration, and sleeping. But again, it's really viewed as a case-by-case determination. And finally, the Individuals with Disabilities Education Act, which is a special education law. It's a federal statute that grants money to states to administer special education programs. Students that are recovering from TBI can qualify for consideration of an IEP under this law. If they, students with concussion who have a shorter recovery time, however, are less likely to meet the eligibility requirements for services under this law. So Child Find, which is a provision under the law, requires a formal evaluation to see if the kid is eligible. If the student meets the criteria for a recognized disability qualification, and that can include TBI or other health impairment, otherwise called OHI, and if that disability has an adverse effect upon educational performance, so that special education is warranted. We did learn through talking to medical experts that most of them seem to agree that the need for an IEP after concussion is rare, but there haven't been any studies done in schools that confirms this. So for future research, one thing that we are working now with the National Association of School Nurses and other partners is really on the issue of communication, streamlining data sharing, really clarifying under HIPAA and under FERPA what providers and schools and parents can share among themselves, really to make sure that the child who's returning to school with a concussion has the services and the accommodations that they need, even in the absence of applicability of these two federal laws. So school nurses can draft a student health plan with accommodations just like an IEP, for example, and is just as enforceable in the schools. And so these kinds of lines of communication, navigating HIPAA and navigating FERPA, are really going to be important moving forward to try to make sure that all of these kids are covered. And that's something that we're working on. And here is my contact information. I would love to hear from any of you. I'm sorry for talking so fast. I just want to make sure I get everything in. And with that, I'm going to turn things over to Matt Swinburne.
Good afternoon. Thank you for allowing me to speak today on something that is actually a very live and developing, I think, public health story that has been resolving this week, but I think it's an issue that's really important for folks in public health to be aware of and to understand. As Kathy mentioned at the beginning, I'm one of the folks at the network who's really interested in food policy and the public health implications of that. So today I'm going to be looking at food insecurity and the SNAP program, the Supplemental Nutrition Assistance Program that some folks still refer to as food stamps, and the impact of the Farm Bill this year. So I'm going to go over a couple basic basic concepts. So when we're talking about food security, we're talking about the access to enough food for an active and healthy lifestyle for all members of a household. And it's kind of a term of art that comes out of work that the Department of Agriculture does to kind of quantify and understand this public health challenge in the United States. So when we talk about food security, it's critical for public health because it has so many health effects for individuals. So if we just look at some of the major concerns with food insecurity, the lack of sufficient food for a healthy lifestyle, you have challenges like increased risk for cancer, diabetes, obesity, and these increased health risks and health challenges come with an economic impact as well. Individuals who are food insecure are greater users of the healthcare system. You know, food insecurity is linked to greater emergency department visits, more frequent hospitalizations, longer hospital visits, and this kind of cumulative effect of the increased health risks and health problems and access to health care costs our country an estimated $160 billion in health-related costs every year. Now, these are some of the major health concerns that we deal with across all age groups. But when we look at food insecurity, we really need to understand that with children, there are additional risks because of their developing minds and bodies. The lack of sufficient nutrients and sufficient calories can have additional negative effects from, before they're even born. If their mother is food insecure, there are greater risks for birth defects. There are cognitive problems associated with food insecurity. There are, other physical developmental challenges resulting from food insecurity. But food insecurity has also been shown to undermine key determinants of health. That, folks in public health, we're concerned with these kind of societal factors that impact the health of individuals. And one of the key things that food insecurity undermines is academic performance. So children who are food insecure have poor academic performance, and they're less likely to graduate from high school. So we have the physical effects of food insecurity, but we also have challenges from a determinant of health perspective. So what is really, the scope of this problem in one of the wealthiest nations in the world? Well, the United States Department of Agriculture does an annual survey to try to quantify the number of individuals in the United States who are struggling with food insecurity. And the most recent report out of the USDA came out this fall, and it looked at the level of food insecurity in 2017. And we have over 40 million Americans who struggle with food insecurity in 2017. So that's almost 13% of our population. And when you look at children, 1 out of 6 children in our country are confronted with food insecurity. And this is a health challenge that has disparities. There are definite health inequities when it comes to this. The USDA has information that compares food insecurity rates between white households, Hispanic households, and black households, and you'll see that food insecurity rates are almost 3 times greater in black households versus white households. Now, USDA doesn't compile data on food insecurity rates in American Indians and Native Alaskans, but independent research has been done on that, and the food insecurity rates, as you can see, are at 25%. So this is a health issue where you have considerable equity issues. So where does SNAP and the Farm Bill come in to addressing this? Well, the Supplemental Nutrition Assistance Program is actually the largest nutrition program in our country, and it helps over 40 million Americans afford the food they need to feed their family. And the basic, if you're not familiar with the program, federal funds are allocated to states. The states then administer this program, which gives participants a electronic benefit card, which is loaded with funds that can be used to purchase food at participating vendor locations. And these funds can only be used to purchase food. And this is an entitlement or benefit that's given to individuals who qualify based on their income. And there are measures that look at a household's gross income, and that looks at households that are 130% of the federal poverty line. It also looks at net income for households that are at 100% of the federal poverty line. So it's a program that gets funds to folks so that they can purchase food when they have the economic need for these funds. And this program is the federal program, as I mentioned, and it is the largest budget item in the Farm Bill. Now, the Farm Bill is this big umbrella piece of legislation that is passed approximately every 4 to 6 years, and it deals with a broad spectrum of issues. It deals with issues of conservation as it relates to farmland, international food aid programs. It deals with crop subsidies as well as crop insurance. It has credit and other financial programs for farmers. There are programs for rural development, but it has its nutrition title where the Supplemental Nutrition Assistance Program resides, and it is the largest piece of that budget for this large umbrella bill. So 2018, this is a farm bill year, and if you've been following this in the news at all, it has been a politically contentious process that has taken over 8 months to reach some sort of resolution. And so when I drafted these slides, it was at the beginning of the week before some key measures had happened. So the story of the bill is that the House and Senate both passed their individual versions that had very different approaches to dealing with the SNAP program. And the House and the Senate could not reconcile their differences with how they wanted to treat the SNAP program. And one of the big points of contention was work requirements for participants in the SNAP program. The Senate wanted to leave key provisions related to the work requirements alone and kind of leave them at their current levels, and the House wanted to make them much more stringent. And it was estimated that the federal government, if they had implemented the House's revised work requirements, would have saved over $17 billion over a 10-year period, but these savings would have come at the cost of between 1 and 2 million people losing their SNAP benefits, so losing the key funds they needed to be able to purchase food to feed their family. And these work requirements, it can get confusing. There have been work requirements in the SNAP program for quite some time. And there are two types of work requirements. There's a general willingness to work requirement that looks at requiring individuals to register for state employment programs, that requires them to participate in training programs. It requires them to accept suitable employment offers, but it doesn't place any specific work mandate in terms of you must work X number of hours. And the work requirement that has been in contention all this year and really since the 1990s is related to what is referred to as the able-bodied adult without dependents time limit. And so back during the 90s welfare reform, this provision was added to the SNAP program through the Personal Responsibility and Work Opportunity Reconciliation Act. And what it did was set specific work requirements in terms of number of hours per week or per month that adult beneficiaries had to meet in order to secure more than 3 months of benefits over a 3-year period. Now, the program had this able-bodied adult without dependents, or ABODs, work requirement had some flexibility where there were waivers that could be granted by the states to deal with issues like lack of economic opportunity in certain communities. Now, what the House wanted to do earlier this year was make these ABOD requirements apply to more people and increase the amount of work that these individuals would need to do to qualify for the SNAP program. So I kind of done a comparison so that you can understand these exact changes, because this is a program where the devil really is in the details. So, you know, the way things are now, people who were subject to this work requirement were individuals between the ages of 18 and 49 who were caring for a child, who even if you were within that time frame, if you were caring for a child under 18 or an incapacitated adult, or you had some physical or mental health issue that prevented you from being employed, you were exempted. But what the House wanted to do was increase the age range of individuals that had to comply with this. So they bumped it up 10 years to, the cutoff at 59 rather than 49. And they changed some of the exemptions where if you're within that 18 to 59 age range and you were caring for a child, the only way you could be exempt is if that child was under 6. So it was a pretty substantial policy change in terms of who this work requirement was going to apply to. And, question is, what are the challenges for taking care of a 5-year-old versus a 7-year-old? You question some of the policy reasoning behind this. So they increased who the work requirement would have applied to, and they were going to increase the number of hours that individuals needed to work. So currently, the requirement is 20 hours per week averaged over a month. They wanted to raise that amount to 25 hours per week starting in 2026. So there was an increase, over time of the number of hours that needed to be worked. But one of the big challenges was how you would deal with accounting for the hours per week. So the House bill really wanted to force the individuals to prove that they had met that work requirement every month. Now, current administrative practices require individuals to report when their circumstances are changed, and states collect data on compliance in terms of the number of hours, not on a monthly basis. So this increased administrative burden on the participant was seen as one of the mechanisms that would actually end up excluding individuals from the SNAP program. Now, I mentioned that states had some flexibility. They could waive this ABOD requirement when there weren't economic opportunities for people to find work. And there are two ways that states could do that. Through geographic waivers, so states could decide, based on employment levels, whether or not to request a waiver from the USDA. So these waivers could be anywhere from a few months to up to 2 years. And for a state to be able to make that request, they had to show unemployment over 10%, or they had to show unemployment rates compared to the national average, a different measurement. Now, a 10% unemployment rate for a state or geographic area within the state is actually a pretty high standard and is a pretty devastating unemployment rate. So the other employment measures would allow a request of the waiver at a much lower unemployment rate. What the House bill was going to do was make it more difficult for jurisdictions to request these geographic waivers and make the unemployment rate that qualified much higher. I'm getting notices that I'm running out of time, so I will jump to the next slide. Another thing that states can do is, rather than granting geographic waivers, they have a pool of exemptions that they can issue to individuals who aren't able to make the employment requirements. And they're given an exemption pool that's equal to about 15% of their SNAP caseload. What the House wanted to do was decrease the number of exemptions that they could hand out to 12% of their caseload. So this is another mechanism that would decrease the number of individuals actually receiving SNAP benefits. Now, where are we now? Well, this week was a big week for the Farm Bill. So with the midterm elections and the change of the political makeup of the House, they went back to the discussion board to try to work this out. And on Monday, they released their proposed bill out of conference. And that proposed bill had removed all of these kind of negative elements to the work requirements that would have kicked between 1 and 2 million individuals off the SNAP program. The House voted, the Senate voted, I think, on Tuesday, and the House voted overwhelmingly on Wednesday on the Farm Bill. So it has been passed and is waiting the president's signature. And, you know, we're thinking, oh, we kind of dodged a bullet on these requirements that will kick a lot of people off this important nutrition program. But in the background, the Secretary of Agriculture, Sonny Perdue, has announced publicly that he plans to propose regulations that would make it difficult for states to request waivers from the work requirements. So one of the key issues that they avoided in the Farm Bill, the Department of Agriculture is hoping to implement through regulation. So the story of the Farm Bill seems to have come to a close with dodging a bullet that would kick a lot of people off of an important nutrition program, but we have regulations that haven't been released to the public yet, but are under review by OMB currently, that could have some of the negative effects that some restrictive work requirements within the bill could have had. So it's a bullet dodged in the Farm Bill passage, but still, I think, a challenge to food insecurity and the SNAP program in the United States. So that's where we are with the story of the Farm Bill, and thank you for allowing me to talk about this today.
Well, thank you, Matt, Carrie, Brooke, and Melissa. We did have a couple of questions pop up in the pop-up box, and I did answer the two of them there, but I'm going to ask you a couple of questions. If you have questions, please put them in the box. I'll try to talk and look at that at the same time. But just, Matt, I just was curious. I think there's some obvious, but what are the other policies that the Farm Bill addresses that are important to public health? And so you touched on some of them, but I know from talking to you that there are others.
Well, there are two that I'm really interested in that I think are critical, that I think have tremendous public health implications. From another nutrition element, there is a program within the Farm Bill called the Food Insecurity Nutrition Incentive Program, and it is a federal grant program that provides millions of dollars to encourage SNAP beneficiaries to use their benefits to buy fruits and vegetables, because in the SNAP program, there is choice. You can use your SNAP benefits to buy Coca-Cola. You can use your SNAP benefits to buy Doritos. You can use your SNAP benefits to buy apples, oranges, and carrots. But what the Finney program does is it doubles up. These funds go to programs out in the community that double up the buying power of SNAP beneficiaries when they use their benefits to buy fruits and vegetables. So it deals with one of the obstacles to, having a healthy diet for low-income individuals is the cost of healthy food. So I think that's a really key element of the Farm Bill, to provide that funding to incentivize healthy choices. But another thing that the Farm Bill does is it has elements to it that focus on broadband access and adoption in rural communities. So high-speed internet should really be considered a determinant of health, because it is connected to so many other aspects of the determinants of health. You know, broadband access creates educational opportunities. It creates employment opportunities. It facilitates, the adoption of telehealth measures in rural communities that lack providers. So there are parts of the Farm Bill that look at providing, loans and grants to kind of forward the mission of getting broadband internet to rural communities. So I think, you know, the Farm Bill is a massive piece of legislation that has huge public health implications.
Awesome. Thank you, Matt. Carrie, so what kind of, I mean, you talked about what happened and that, you know, over the course of time from a legislative perspective, and so I'm wondering what's next. Look into your crystal ball. What might we see next?
Well, so I mean, I really think that we'll start to see more of the same. I think that states are learning things as they've been implementing their laws over the past several years, and so I think that they'll start to tighten requirements based on research, and mainly I think we'll see a lot of clarification of the language in their specific state laws as they learn these lessons. Another, I mean, I do think we'll see more return to school kinds of efforts, maybe more specificity with those requirements, what a return to a school process should look like, who should be doing what within the schools. And also I think we'll start to see more of this, like we saw in Maryland with the no contact football before the age of 14 and provisions like that, as the research really tells us that the subconcussive hits under that, you know, for younger kids is really causing a lot of the problem. Yeah, so I think that's what we'll start to see in the future.
Great, thank you so much. Brooke, I am going to turn to you with actually the same question. So this is a totally unfair one to throw to you, but what do you think the FDA is actually going to do? I mean, we've heard what they've talked around and through and about, but any predictions on what they might actually do in the near term?
Sure. All right, so I think there has been quite a bit of talk about flavors, and we saw that in at least two of the three press releases, and so I have a sense that they're going to act very quickly with respect to placing severe limitations or banning flavored vape products. That would be my sense. One of the companies, it may have been Juul, announced recently their plan to limit or reduce some of the flavors from the market as well, and so that tells me that potentially there's been talk between the two. This is going to go into effect, and this is a way of kind of Juul getting ahead of it. So that is one of my guesses about what they might do. I also think it's likely they're going to start limiting where and how these can be sold as products, and so I think they may start placing limitations on whether they can be sold online, and they may also do something about selling these in just, you know, any old convenience store. They may just place these in, you know, age-restricted locations, 18+. So those are kind of the two directions I see this heading.
Great, thank you so much. So Melissa, coming back to you now, the question that I have for you relates to expanding pharmacy scope of practice. So in my head, I can kind of understand the nursing and dental, but what about the pharmacy scope of practice? What types of expanded services or skills are pharmacists allowed to use in these expanded scope laws?
Yeah, I touched on it just briefly, and pharmacy is one of the really interesting ones because they're really creating new tasks to interact with patients. So as opposed to nurse practitioners that are engaging with patients regularly and maybe they want to do a little more with their patients, this has really created a completely new relationship. So pharmacists are in a unique position where they have contact with a wide variety of patients on a very regular basis, more so than doctors or nurse practitioners or dentists. And we see these patients are coming into the pharmacy regularly to refill their prescriptions. We see them come in to get over-the-counter things that they're doing a consultation with a pharmacist on. And then through scope of practice changes, we're able to empower the pharmacist to actually engage in those activities and then the hope long-term is reimbursement for those activities. So we're seeing pharmacists trained to, for instance, manage someone with a heart condition, and so maybe they're taking the patient's blood pressure each month when they come in for a prescription refill, and that eliminates a co-payment for a doctor to go see every month. A patient most likely isn't going to get into a doctor's office every month, whereas they are going to get into the pharmacy to refill their prescription. And so if we're empowering a pharmacist to do a simple check like a blood pressure check, and then maybe empowering them also to adjust a medication slightly, they're educated to do that. They oftentimes know the medication, I don't want to say better than a doctor, but they're very informed about all the new medications coming out. They're touching medications on a regular basis with a variety of patients. And then we empower them to use that knowledge to really impact patients on a more regular basis.
Wow, thank you. I mean, when I think about that, I think, you know, because there's a pharmacy in my Walmart, I feel like now I can go to the Walmart and pretty much buy anything that I need, and I can also get my nails done, my hair done, my eyes checked, and now actual medical care through my pharmacist there. So,
yeah.
I don't know. That's pretty awesome. Or it's scary. I don't know which, or a little bit of both. To the folks who remain on the call, which, you know, we've actually been able to maintain the vibrant attendance throughout the course of it, so hopefully that was because you found it interesting. I just want to say thank you for hanging in there. Thank you for being a part of the Network for Public Health Law. As we close out 2018, we look forward to serving you in 2019. Because you hung in there this long, I'm going to give you a little in that the Eastern Region is hosting a regional meeting here at the University of Maryland Carey School of Law on February 13. We will have a panel discussing preemption in public health, discussing immigration in public health, and a variety of other issues. And so I'm going to make sure that those of you on the call right now will get an actual invitation to that event should you be interested in attending and meeting all of the folks who were on here today in person. And I just want to say the one thing I didn't mention when I read each of their bios is that part of their job description is to make me look good and like I'm actually doing anything here. And they just proved today again that they do that well. All I had to do was sit here and listen to them, and they made the Eastern Region very proud. And so I want to thank my colleagues and wish you all a happy holiday season and the best new year.